recording here. So if we talk about equipment, you break it down into pieces, you know, the endotracheal tube, which, you know, the advantages of an endotracheal tube is obviously a more efficient delivery of anesthetic. And going back to my class, you can deliver oxygen and anesthetic via a mask and keep a patient asleep with just a mask. I mean, the disadvantage is you have exposure to personnel. So, you know, that rubber black gasket on the mask isn't a perfect seal. And just remember, because, you know, besides James and Clayton in here, if you're thinking of having children, and I know a lot of times people don't want to tell people they're pregnant initially. My bosses have always known when I'm pregnant, even before family. You'll want kids someday, James, don't worry. But the problem is people think, oh, if I don't smell the gas, I'm not exposed. This fact I always give: you are exposed at 5 parts per million. By the time you smell anesthetic gas, you're at 50 parts per million. So you cannot just say, oh, I don't smell gas, I'm fine. And I just make that as a disclaimer to make sure you're being very careful. You know, so masking has a high risk of exposure. If you, yeah, and some people do have altered smell. So I don't like to use the smell test to say, oh, I'm fine, I'm not being exposed. Because it has been proven that small amounts, you are exposed, even if you don't smell it. So I'm just, you know, first of all, masking, you have, you know, high risk, not to mention that you have all those open airways. Gas has to go from the nasal cavity all the way till the alveoli to diffuse. When you intubate an animal, you close anatomic dead space. You bypass the nasal cavity, the nasopharynx, and you get down to the bifurcation of the trachea. So you're bringing the anesthetic much closer. So first, that's what dead space is. To review, and again, I feel like this is a board thing, dead space is any area of the airway that is non-functional gas exchange. Gas exchange occurs at the alveoli, at the capillary. So every part of the airway, all you're doing is moving the gas closer to the alveoli. So obviously, endotracheal intubation, the benefit is you decrease the dead space. You take away all that area of non-functional gas exchange. So that's the number one benefit. Not to mention, it's a more precise delivery. Okay, you're going closer to the lungs, closer to the alveoli. And it also protects the airway because when you inflate the cuff, then first of all, that prevents leakage around the endotracheal tube. And remember, it also could prevent aspiration. So you're also protecting the airway. And I don't know if it's happened to any of your patients, but sometimes you'll get, during the procedure, you'll get passive regurgitation. Like you'll notice some stuff comes out of their nose, or sometimes it pools in their mouth. They'll get some stomach contents. So even if they're not actively vomiting, you do have regurgitation that you have to be cautious of. So these are all the benefits. And again, if you have an animal that arrests, you already have a patent airway. So you can bag the patient and deliver oxygen and breathe for them. So there's many benefits. You know, monitoring respiration too. You guys have probably seen this. When they breathe in and out and they fog the tube, it's a way to monitor respiration, as long as you're not using those, you know, other tubes. The more common ones you guys have seen are those of the Murphy tubes. They have that hole. And remember, the purpose of a Murphy eye is not to hang it on the wall on a hook, which a lot of people do. And that's fine, you can do that. But it is to provide another open, if the end of the tube was to get clogged with mucus or, you know, secretions, they can access air through that side eye, that Murphy eye. And then the cold tubes do not have the cuff of that, but the cold tubes are primarily used in birds and reptiles. Although Niemer has told me they do use cuffed Murphy tubes in exotics. They come very small. The smallest I use on a cat, you guys have probably used either 3.5 endotracheal tube, or kind of, you know, 3 is like my average cat will take a 3.5 tube. I put a 5 endotracheal tube in a Maine Coon. I had a huge Maine Coon, and he had like a honking trachea. you want to always, and hopefully you've noticed this intubating, you always want to use the biggest tube you possibly can. You don't want to have to inflate the cuff too big. Like you can put a 7 endotracheal tube in a Rottweiler, but you're going to have to inflate that cuff to meet the diameter. So you're going to want to always pick the biggest tube you can get in, and you don't want to force it. And so, but again, when I used a 5 in that Maine Coon, I also had to put a 5 in this one Frenchie that was getting an MRI. That dog had a tiny, tiny trachea. So again, you can't always use body size for your diameter. Here's the tubes. Again, this B right here is the coal. This is your standard. Letter C is called the polyvinyl chloride, which is the clear. And then the top, which I love, those are silicone. They have like a lit. Cuff inflation, James, it shouldn't. So if you look at these tubes right here, this cuff, when you fill it, should just go like laterally. It shouldn't go and cover the end of the tube, and it shouldn't compress it. But I did have that nightmare case. I think I've shared this with you guys, where I went in to check a dog. The girl, you know, is a vet student. She's like, he's not breathing. And I go in there and the dog is blue and he's gasping for air. And so I disconnected him from the machine because I thought it was a machine problem. He still couldn't breathe. So now I know, I thought his tube was clogged because he wasn't moving air. He was gasping, he was blue. The rebreathing bag was huge. And then when I went to deflate his cuff to pull his tube, to change his tube, it shot my plunger across the room. And she had said she had put like 6 or 7 or 8 syringefuls, 12 mil syringes in the cuff. So I think and that was kind of an extreme case where I think maybe the cuff inwardly compressed, or the cuff did come around the end of the tube. But that's just to give you guys an idea. When you fill a cuff, you know, one 12 mil syringe of air, if you use the proper size, should give you enough air to fill that cuff. She thought she was hearing a leak, so she kept putting air in. I wasn't in the room when she was doing it. I had 2 cases. So she kept thinking a leak, and I think she was just hearing air move in the tubing. So it was just a mistake. But that's about the only time I've heard that. And remember too, your cuff should never be too tight where you can't pull the tube in an emergency. It's not to hold the tube in the trachea. It's just enough to not allow leakage of anesthetic gas or to prevent aspiration. That's the goal of the cuff. This top tube is the silicone. They're more expensive. They have a little bit of a tinge to it, but silicone is very soft and pliable, causes less irritation. But most clinics, and then a few older hospitals, if you go to an older clinic, you might see some of these orange tubes, which are not, they're called like red rubber tubes, even though they're orange. But they're not, let me go to the next slide. So the polyvinyl chloride is the clear and it's stiff. They're cheap. I mean, most people, that's the standard tube. And then the red rummer, they're very flexible and soft, but they are absorbent. Of all of the materials, if you leave this sit in the solution, like the Chlorohex solution, it absorbs that cleanser. And the problem is if you don't clean them well enough, you go to put that tube in the patient the next day, and it can cause mucosal irritation, because what happens is when you put the tube in, the humidification and the warmth of the airway is going to cause a release. There was a study, there was a bunch of cats with like a tracheitis, there was a coughing, animals are going to cough. This is practical. Okay, let me give you guys a practical tip because you're going to externship. When I would discharge clients, their dog was intubated, and I'm like, your dog may have a slight cough for a day or 2, but it should get better, not worse. It should not be a cough that interferes with eating or sleeping. So I didn't like, if they felt like their dog couldn't make it through a meal or was waking up all night and couldn't sleep, and if the cough gets worse or becomes a productive cough, usually it's just kind of a dry irritation. It's not like a I'm hacking stuff up. That could happen. I mean, dogs can potentially get, post-op kennel cough or a post-op pneumonia. I mean, those aren't common, but that's something I let the client know. You need to call us back. I mean, if it's 2-3 days, if it's day 3 and your dog is still like hacking up a lung and also becoming like a productive cough, then, the doctor needs to take a look at them, because that's, they are going to cough post-op. I mean, people cough after they've had surgery, but it shouldn't be a cough that gets worse, becomes productive, causes interfering with eating and drinking and things like that, sleeping. So that's just a goal. Now, and the silicone they're very strong, less irritating. The only thing is they sometimes can get punctured sometimes a dog can bite down because they are so soft. So that is an advantage to the polyvinyl chloride. If you remember, there are marks on the tube, which the centimeter marks just tell you how far in. But you guys know you measure to the thoracic inlet. You don't want to go past the thoracic inlet. The number, when I say go get a patient an 8 tube, you're going to be using the ID number. There's an OD, which is outer diameter, and there's an ID, which is inner diameter. And the inner diameter is the number that we use. And again, all the way, I mean, I've never used a size 1 tube, but, we kind of have maybe 2.5 or 3 through, now in dogs, we had like 14 and 16 millimeter. They're kind of like shoes. They're individual half sizes till you get to 12. And when you get to 12, then they go 12, 14, 16. So they start going by twos. So the biggest I would have, we had a 14 and a 16. Because, you might have like a Great Dane or a Mastiff that could take a 14 or a 16. When you get into large animal, you're getting into those, 20, 22, 24 sizes. So that's just different. So the different ends, again, letter C here is the part that hooks up to the breathing system, and then you've got I is the side that goes into the patient. You guys have all been intubating, so that should be good. And here's your inflator, which is like a quick release valve. So you guys have all probably filled cuffs already, and you got to kind of push in and give it a half twist to kind of unlock, and then you can go ahead and fill. And then I give it a half twist as I pull the syringe out. So now the chamber induction, I am not a fan of. There's only been, usually for aggressive patients is the advantage, where you've got them in the anesthetic chamber, and then it has to have 2 tubings, one for the inhaled gases. So one hose is hooked up to the inhalation valve. Now you would hook up, when you do this, you guys, usually the chamber comes with the tubing. So normally you've got one hose would hook up to your inhalation valve, and one would go to your exhalation valve, and then they would hook up to either. On the top, it doesn't matter. On the top, it can go, but one is bringing in gas and one is relieving gas. The thing to remember about chamber induction is you're going to need a higher oxygen flow. This is not your calculated oxygen flow. I normally run 5 liters of oxygen, and I usually run 4 to 5% on ISO, 6 to 8% on SIBO. Now, usually when you put a cat in a chamber, they're usually aggressive, and we may not have pre-meds on board. Obviously, if you have an animal that has drugs on board, you may have to use the lower percentages. But the goal is to get them asleep, but it's associated, first of all, there's a high amount of waste gas, because when you open that chamber, we kind of try to back up, and I usually have somebody that can take it into an area where there's not a lot of people. And you don't want it, you're going to get a blast of gas. So there's going to be exposure, no ifs, ands, or buts. It's also, you can't take a heart rate. You're not going to be opening this every 2 seconds and taking a heart rate. So all you can do is observe You know, are they falling asleep, and are you seeing them breathe? That's about, sometimes they'll push up and you can look at their gum, but the problem is you can't monitor the patient closely, and it's very high stress. If you guys remember stages and planes of anesthesia, stage 2 is excitement phase. And the advantage of like propofol induction is you can go from stage 1, which is sedation, to stage 3, plane 1, which is general anesthesia or anesthesia. And you pass through stage 2. Remember I said good induction, you don't see stage 2. That's excitement. When you mask and you chamber induce, whenever you use gas as an induction, you have a higher likelihood you're going to go through that stage 2, and you can get paddling, struggling, vocalization. And anytime they're struggling, vocalizing, paddling, they are having catecholamine release, that's stress, which can increase blood pressure, which can, predispose. Also the catecholamine release, we can get, these potential arrhythmias. It's very stressful for the patient. So I have to have a good justification to use a chamber, which I've talked about in lecture before. Now the anesthetic machine, which its job is to deliver oxygen and anesthetic in a controlled environment. The one on the left is large animal, the one on the right here is small animal. And again, they have the same exact parts, they're just bigger, bigger. That's a huge rebreathing bag. That's probably a 30-liter bag. The biggest bag we have is a 5-liter. You've got a breathing system here. You have soda lime, vaporizer, scavenge. So it's all the same thing. Remember the advantage, or when I was in large animal at Purdue, we had a small animal machine. Anything under 300 pounds can use a small animal machine. So if we had like a foal or a calf or a goat, we could use a small animal machine. But if it's over 300 pounds, then it would get the large animal machine. So remember some keys here. The carrier gas is oxygen. Nitrous oxide we don't use as a carrier gas. The only time, and I only talked about nitrous briefly when we had, sorry, I'm gonna mute everybody here. Nitrous oxide is a medical gas, and it's used to enhance analgesia. I got to use it a little when I was at Purdue. And the thing with nitrous oxide is it's used as an adjunct. If I needed to decrease my inhalant, like if my patient was having side effects from the inhalant, I could add a little nitrous oxide in as a mix. But the carrier gas, the inhalant, like isoflurane, was being delivered via oxygen. And then nitrous was mixed in. There was two flow meters. There was a nitrous flow meter and a oxygen flow meter. So I'll give you an example. If I wanted my patient at 1 liter of oxygen flow, I could do 0.8 liters of oxygen and 0.2 liters of nitrous, which is 800 mils and 200 mils. It gave me a total flow of 1 liter, but my oxygen was always higher. The only reason I'm saying this is because the board exam. I doubt any of you guys would use nitrous. If you're in research, maybe. Teaching hospital, maybe. I don't even think we have it at VCA, and we do brain surgery. So, I mean, we do some pretty advanced stuff there, but I don't even think anybody's using nitrous there. It competes for oxygen, and that's a very board exam question. So the problem is when an animal gets nitrous, it wants to compete for gas spaces, which is your alveoli. So the problem is if you run too much nitrous, it's going to compete, and oxygen can't get in the alveoli. That's why, I don't think I even ever ran 50-50, like half nitrous, half oxygen. It was always more oxygen than I had nitrous, but it was an adjunct, is what I'm trying to say. It enhances analgesia, but again, once you stop nitrous, that's gone. So we would still give the dog a pre-med like a morphine or hydro or butorphanol, they still need a primary analgesic because, again, once you turn off nitrous, that is going to go away. Now, that's what you guys get at the dentist. When you go to the dentist, you'll get nitrous probably by itself, but that's a little bit different. So I'm talking, how do we use it in veterinary medicine? The other thing is the anesthetics have to be vaporized. They are liquid that turn into a vapor. To carry it to the patient, we use oxygen. So oxygen is the carrier that delivers the vaporized inhalant anesthetic to the patient where it can diffuse into the alveoli. So the mix, when you deliver gases, they're mixed. It's an oxygen inhalant mix. Now, what you guys have experienced, once you turn off the vaporizer, when you turn a vaporizer to 0 or off, and your oxygen's still on, then you are just delivering oxygen. But once you open up that vaporizer, you're going to get a mixed gas, vaporizer and anesthetic. The other thing the machine has to do is give a way for exhaled gases to leave out, and that's off the pop-off, out the scavenge system. Now at school, in surgery, and in the prep room, that pipe in the ceiling is what's called an active scavenge. It's actively pulling, like a suction. So when the animal exhales, it pulls the exhaled gases to leave. If you're the dental station, you guys are using that carbon filter, that F-air, or is that charcoal? Yeah, that F-air canister. And so when the animal exhales, that's considered a passive system because it's not actively pulling. When the animal exhales, it'll absorb the exhaled anesthetic, and you weigh it and dispose of it periodically. You guys, since you're going on externship, I've seen these hoses laying on the floor. I've seen them stuck out a window because, you know, surgery had a window. If you stick it out a window, or my old clinic in high school had a pipe that went through the wall, and we hooked it up to the pipe. Now, you were relying on the breeze outside. That's still considered passive. If it's out a window, if it's on, please tell me it's not on the floor, because then you're breathing that. So it's got to really, you know, ideally you'll be on an active scavenge, but at least if it's out, a pipe out the window or a pipe out the ceiling, you know, the airflow outside, if it's a breezy day, it's probably going to pull more. And if there's no wind, it's not going to pull as much. But those are called passive scavenge. So on a board exam, if they talk about scavenge systems, you've got 3 options. You've got your active scavenge, which is a suction unit, a passive scavenge, which is just maybe out a window, out a pipe, out the building. And then you have F-air canister, which is passive, but that's absorbing the anesthetic that's being exhaled. Okay, and then all the machines have to have a compressed gas supply. If you guys remember, compressed gas is your oxygen tanks, okay? It's compressed into a tank. Green is oxygen. If you remember, they are medically coded, like yellow is medical air, green is oxygen, I want to say black is nitrogen, nitrous oxide I think is actually gray. So they have different colors and different pin coding systems. If you remember that, your oxygen, when you guys put an oxygen tank on your anesthetic machines, the pin, it wouldn't let you, say you had nitrous tanks, you couldn't put a nitrous tank where the oxygen tank goes because the coding system doesn't set up the pins won't fit, basically. So there is, so color is a safety mechanism, and then the pin system to the tank is, and then the tubing is also, you know, the oxygen tube is green. So the color coding is so that we make sure, you know, everything's correct. If you remember the 2 kinds of vaporizers, the kind you guys have in surgery that most of you will, if not all of you will use, is a precision vaporizer. It's temperature controlled, and it's controlled for the agent. Remember, ISO vaporizer needs ISO, SIVO needs SIVO. If you screw up, and people make mistakes, it's okay. If you were to accidentally put ISO in a SIVO vaporizer, you have to tell someone, because they need a specific vaporizer because they have a specific vapor pressure. And that control of that agent is dependent on that vaporizer. So now the vaporizer, if you remember, precision vaporizer was also called a vaporizer out of circuit. Let me go to this picture and it'll explain. So if you remember this lovely picture that we had, when you guys turn on your vaporizer, it leaves to your patient at the outlet of the vaporizer, and then it goes into the breathing system. So, and so when I say circuit, circuit means your breathing system. It's just another way to say circuit breathing system. So you could call it a vaporizer out of breathing system, but it's called a VOC, a vaporizer out of circuit. That allows you to deliver a precise amount to the breathing system. You can control it. If you remember, the older kind of vaporizer I talked about was called a vaporizer in circuit, or a non-precision vaporizer. And that would be a vaporizer that, let me see if it's, no, I don't have, okay. So a vaporizer in circuit means that the vaporizer, this is the circuit right here. So here's your Y piece, here's your inhalation valve, inhalation tube, exhalation tube, exhalation valve. This is the circuit, think circuit, circle system. These are all things that our breathing systems are called. In the older systems, there was a vaporizer right near the inhalation valve. It was like a jar and a wick, okay? It literally was a jar and it had a long wick, and you would pour the anesthetic in the jar, okay? Think of an oil lamp, olden days. But if you go to like open up the wick would pull up more oil and make the flame bigger. If you turned it down, which would squeeze some oil out of the wick, the flame would go down. When you use a non-precision, that's literally what it means. What would happen is the animal, when they would inhale, okay, when they would breathe, they would pull oxygen over that jar and wick, and they would pull oxygen and anesthetic to themselves. Now, the reason it's not precise, first of all, there was a little valve you could open and close. So if you opened it, more anesthetic would wick up to the patient. So say your patient was light, you might just open it up, more gas would come up the wick, and the patient would breathe in more anesthetic. And if they got too deep, you could turn it down and not as much would wick up and they wouldn't take in. But that's not precise. Also, which is key to understand, is a patient's respiratory rate and effort could affect the concentration of anesthetic. If they're breathing rapidly and deep, they're going to pull more oxygen through that wick. And if they're not breathing, if they're apneic or not breathing very often, then they're not taking in as much. So when a vaporizer was in circuit or non-precise, the anesthetist didn't have as much control. When the one you guys are using is over here, it's outside of the system. So the patient could be breathing 4 times a minute or 40 times a minute. If you're delivering 2% ISO, that patient is getting 2% ISO. Their respiration rate makes no difference whatsoever because the vaporizer is outside of the circuit. So the reason I'm stressing that is that's a perfect anesthesia board exam question. Is like, well, first of all, which system do you have more control over? Obviously the precise. What is the downfall? And the other thing, the newer agents that we have today, isoflurane and sevoflurane, because they have such a high vapor pressure, they want to turn into a vapor like that, okay? So the problem is, I've told you guys this before, if you put isoflurane on a cotton ball and you stuck it in a mask and had your patient breathe it, they could reach up to 30% isoflurane. The max you deliver is 5%. Okay, that's 6 times what you would deliver in a vaporizer. So the problem with the jar and a wick with ISO and SEVO is we don't have control of that amount. So when they developed the isoflurane and SEVO, you needed a precision vaporizer, and that's because of vapor pressure. That was why that came about. Okay, so we'll come back to those pictures. But your compressed gas is oxygen, and you know, when they're on oxygen, they're getting 100% oxygen. You know, if they're breathing room air, I think it's like 21% oxygen. So you're delivering the two main reasons. Well, number one, oxygen is used to deliver the anesthetic, but also to maintain your cellular function. Okay, so the body under anesthesia, you're at a lower metabolic rate, you have CNS depression, but cellular function, you're giving oxygen to maintain cellular function and to deliver your anesthetic. The two main systems, or the two main tanks, are the E-tanks, which are the ones you guys use in surgery. There's the small E-tanks, and they're typically portable and they're attached to the machine. Now, some hospitals will work off of H-tanks. Now, ironically, both of those tanks hold 2200 psi. An H-tank just holds a lot more compressed oxygen because it's a bigger tank. And the H tanks typically are attached to a wall somewhere in your hospital. Might be like, say like a boiler room or a storage room. And then there's oxygen lines that run to the areas, like run to surgery, run to the prep room. So this, when you go to a hospital, you're probably more than likely going to see this, is you would take the green hose and hook it into an oxygen drop, which is in the ceiling, and you plug it in. Okay, so that is how they currently do it, is plug it in the ceiling, and if you're using an H tank. And one thing to understand too is that if you're using an H tank, well, E tanks, anytime you're storing tanks, any type of pressurized gas, they have to be chained, or like in a rack. The H tanks are typically bolted and chained to the wall, because if they fall over, they can turn into a missile. So it's a major OSHA violation. You have to make sure that your oxygen tanks, you know, you don't want to never set an oxygen tank just sitting in the middle of a room, because again, it falls over, it can, I mean, it can be bad. So that's a big no-no. So oxygen's highly combustible. The yoke attachment, that's the part, the yoke is the part on the machine where the tank attaches to. So the yoke is on the machine, and you put the tank and hook it up to the yoke. They have to be stored, again, against the wall, chained. And oxygen is green. It's white in Canada, but oxygen's green. So sorry, nitrous is blue. Carbon dioxide is gray. Okay, you're probably not going to work with carbon dioxide. You might see nitrous, but more than likely not. If you remember, on the oxygen tank, when you hook up oxygen and you turn it on, it's going to read, a full tank will read 2200 psi. Now, that would blow up your machine. So right after where you have the oxygen pressure gauge, somewhere right after that is what's called the pressure reducing valve. And that reduces the oxygen to safe operating pressure. And that is always set between 40 and 50 psi, pounds per square inch. So your tank, oxygen pressure, and line pressure is all measured in psi. And again, 50 psi is safe, and that's what's running from the oxygen line to your machine. And again, that's something you shouldn't have to adjust. Like, that should be set and you should be able to leave it. So some tanks, this is just to review, you might have the first gauge, and if they had pictures of this on the test, who knows, but the first gauge, if it says, you know, 2200 psi, that's the tank. Then you'd have the reducing valve, which looks like a knob. And then sometimes there's another pressure gauge, and that's called the line pressure gauge. Let me go back a second. So if you look on this picture, tank pressure gauge, which full is 2200, and then you have your reducing valve, this should read 50 psi, and then that's what's going to your flow meter. So that's setting the pressure to your flow meter. And again, 50 is normal. And then you go to your flow meter. Now your flow meter, so here in this picture, and see how this is kind of blue, it almost looks black, but it's blue. So here's your nitrous oxide flow meter. Here's your oxygen. So even the flow meter is coded green for oxygen. So sometimes the knob is green, sometimes the background is green, but it'll usually say oxygen somewhere on it. But this is set in liters. Now, your oxygen flow meter further reduces the pressure down to 15 psi. So you go from like 2200 down to 50 psi. The max that can leave the flow meter is a 15 psi. So it's a further reduction. But this is liters. So if you look at this picture, at the one, that is 1 liter, which is 1,000 mils. So if you are here, you're at 700 mils, which would be 0.7 liters. And again, you calculate your oxygen flow. A lot of people default put animals at 1 liter of oxygen. The minimum you can run, that you should run to a patient, because sometimes, you know, oxygen costs money, anesthetic costs money. The more oxygen you run to your patient, you're sending more gas from the vaporizer. It does cost money. But you don't want to run below 0.5 liters or 500 mils to your patient. A lot of times when you calculate their metabolic oxygen requirement, you might even get lower flows. But the problem is the vaporizer needs at least 500 mils of oxygen flow to guarantee that if you set 2%, you're delivering 2%. The company says if you run below 500 mils, we're not going to guarantee you're delivering what you say. So we never went below 0.5 liters. So we pretty much that's what went to the patient. But you can, you can adjust this and we can control the amount. And if you remember, I'll just finish on this because we'll get through it. You do have the flush valve, which is usually somewhere near the flow meter. And that will give a short burst of oxygen. But the key with the flush valve, if you look at the tubing on the back and the piping, it goes around the vaporizer. So when you hit that, you're delivering fresh burst of oxygen to your patient, except that you're delivering at a very high rate, a lot of pressure. So I don't use flush valves with non-rebreathing systems or very small patients. And you should do, instead of holding it, I do short little bursts. So it's like, and you'll see your bag. A lot of people use the flush valve to fill the, remember I told you guys there's only a couple times, why would I use it during a procedure? Well, if I was doing CPR and I had to fill the bag quickly, or I was waking up the patient at the end of a procedure and I wanted to dilute out my anesthetic to wake them up. Because you'll fill your bag with oxygen and you dilute your anesthetic. You don't want to do it when the patient's getting light. Like if the patient's huffing and puffing, and a lot of times you go to bag them and your bag isn't full. People, and you may work with some on-the-job trained people that don't know this, but a lot of people hit the flush valve and then they bag the patient. You are lightening them up by doing that. Because every time you hit that flush valve, you're diluting out your anesthetic and giving them oxygen. Well, if you're trying to make them deeper, you're working against yourself. Now, in situations where I have to fill my bag and bag them quickly, I will crank up my oxygen flow meter, and that'll bring oxygen and anesthetic and then bag, okay? You can also use it to fill your system. But I want to make one comment now that, when you guys go to your externship sites, and I don't know if you're going to go there now or you're just going to start next week, on a slow morning, or maybe go in a half an hour before you're supposed to be there or whatever, Find their anesthetic machine and play with it. And I've showed you a way to hook up tubing and hook it up to a rebreathing bag and act like it's a patient. I would find the flush valve, the flow meter, make sure I know where the scavenge is. You don't want to go into surgery to help with surgery, and that's the first time you're looking at that machine, because you guys get spoiled at school. The machines at school, everything's labeled and everything's laid out very nice and very pretty. Some of you are going to go into clinics that have maybe very old machines. They all have the same parts and they all work the same way, okay? It's just maybe set up differently. But I tell my students this all the time. I said, it would make me very uncomfortable to throw me into surgery when I've never looked at that machine. And there's no excuse that on some off day, even if you have a half hour for lunch, go into surgery when it's not being used and familiarize, first of all, where are their emergency drugs and how do I use the anesthesia machine? Those are two things that I would do before I had to help in surgery so that I know where they are. That's just, like I said, at VCA in the prep room, we've got like 7 different anesthetic machines. They're all different. And one looks like it's from like the 50s or something, but they all work the same way. So that's just my advice. Make sure you're comfortable with the machine before you actually have to use it for the first time. Okay, I will stop here, and are there any questions?